Good afternoon, everyone. So hopefully everyone had a great lunch. It was a little bit of a dash there to get back. So we're going to talk about Section J, and then I'll go right in and we'll talk about Section M, skin. So in preparation for the work that we're going to do with Section J and Section M, I think some of these things you already have out and about. And for those that are watching via the web, we are going to use the case study. You have your planned discharge form that you've been using. There's two additional documents that are, if you're here in the room, they're in the right side of your folder. And I'll actually have you go ahead and pull both out. One is coding scenarios for Section J, and these are just kind of blank. We're going to have 3 different scenarios that you're going to practice, and you can write on there. And then we have, as we move into the next hour after this, Section M, coding scenarios, but you can go ahead and pull those. And these are available in that same zip file that you've been gathering data for the previous speakers. So we have that. All right, so we're going to talk about Section J. And so where we start off with our objectives, hopefully we'll have a working knowledge of Section J, health conditions, specifically falls. We're going to be able to hopefully understand the intention of Section J, be able to interpret the coding options for the new items and when to apply it, and then ultimately hopefully apply the coding in order to accurately code practice scenarios, the case studies, and most importantly be able to actually do this back at your organizations. So all items in Section J are new to the long-term care hospital care dataset, version 3.0. And the nice thing about having this group here, and hopefully those of you on the web, that you've actually been using this now since April of 2016. We've got lots of great questions, and hopefully we'll have answered most of the questions that have come up from the previous trainings, webinars, and come into the help desk. So hopefully we will, by the time we're done with this, that we will have answered everything. But we have J1800, any falls since admission, and then J1900, number of falls since admission. And we do these on planned discharge, unplanned discharge, and expired. Those are the assessments. So the intent here is to code any falls since admission, including any injury caused by the falls. So this is the opportunity to go ahead and code in this section. So the definitions, let's talk about when we're coding what is a fall. It's an unintentional change in position coming to rest on the ground, the floor, onto the next lower surface. So they're standing and then they kind of fall into the chair or they go to the floor, whatever. These may be witnessed, they could be reported by the patient or an observer, or identified when a patient is found on the floor or on the ground. Now, the one caveat here is we do not count a fall as something that has resulted in overwhelming external force. So if someone is pushed and they fall, an example that was given in yesterday's training is someone comes flying through the door flies open, hits the patient, they fall to the floor, and they have an injury. The external force there was the door, they ended up on the floor, that's not a fall. Okay, so remember that. So it's that external force that's happening that caused them to go to the ground. Okay. So that came up as actually in the frequently asked questions. So the intercepted fall is the one that has caused probably the most discussion and frequently asked questions. So we want to try to spend a little time about having you understand what's the intent here, what are we trying to get to. So an intercepted fall occurs when the patient would have fallen if she or he had not caught himself or herself, or had not been intercepted by another person. This is still considered a fall. So some of the questions that we've gotten and some of the concerns that we've had is, especially around in the type of patient when we're working with them and let's say they've had a major stroke or injury, and as part of our treatment plan, we're challenging that person. We may be challenging their balance and whatnot. So the idea that if you don't, let's say you're challenging them and you're doing a gentle push, and now you're having to kind of keep your hand there and have them right up, that's not an intercepted fall, okay? So the idea here was really that person, they're walking down the hallway, let's say they stumble, they fall, they can hit into the wall, they grab the side rail, they keep themselves from falling, and you witness that. That, in fact, would be an intercepted fall. If it's part of just the normal care plan, you're doing all the things that you need to do, and they still have this kind of major sudden, forward or backward or side, and you're having to go, oh, and you're really kind of grabbing and helping and either then lowering the person to the ground or you're strong enough and able to keep them upright, that in fact could be an intercepted fall. So we hope that that helps. So the first question, J1800, any falls since admission? First off, this item is not, and this came up as a frequently asked question, we are not looking to see that if the person had an intercepted fall. So that was a question, like how do we get that piece of information, like from family and whatnot? We're not looking at that. So we're just looking at, has a person had a fall? So we know that falls are the leading cause of morbidity and mortality. And someone who's fallen and had a major injury or they've had a significant fall, the fear of falling can limit the individual's activities and negatively impact their quality of life. They can be hesitant to engage with you and to be able to challenge themselves because that fear of, oh my God, I don't want to fall. And so I'm not going to do it. I'm not going to do it. So just the fact that someone has fallen, we probably have to work through that and have the person trust and work with us. So what do we do for steps for assessment for J1800? Well, first, we can look at the medical record. We can look at, and these are just suggestions, so look at your particular organization. Where do you record things? Physician notes, nursing therapy, nursing assistant notes. You may have incident reports and fall logs. You want to make sure, to go through and talk with everyone. So here in J1800, we're going to complete for planned discharges. We're going to complete on unplanned discharges and then the expired assessment. So it's all of those assessments. We're going to code no if the patient has not had any falls since admission, and we're going to proceed to the next section. Or we're going to code yes if the patient has had a fall. If you code 0, there's a skip pattern. So if you're doing this on an electronic form, it usually then just automatically jumps you to the next question that you need to answer. But if you're doing this on paper, then you would skip to M0210 and then complete that. All right, so let's look at some coding scenarios. So Mr. B was found sitting on the floor at the foot of his bed, and he stated he was walking to the bathroom and he slipped. 1 hour earlier, he had been medicated for insomnia. Upon physical examination, Mr. B was noted to have a bruise under his right eye and a superficial laceration on his right forearm. So in this scenario, how would you code J1800? Any thoughts? Yes or no? Yes, okay, right. Any falls since admission would be coded as yes. All right, so in the next scenario, this is actually going to be a practice scenario, so if you pick up your little coding devices, that would be helpful. And for those of you on streaming, you may want to jot down your answer as we move along. So an incident report describes an event in which Mr. S was walking down the hall and appeared to slip on a wet spot on the floor. He lost his balance, he bumped into the wall, but was able to grab onto the handrails and he steadied himself. So in that scenario, you were able to capture this information. How would you code J1800? Has the patient had any falls since admission? So just go ahead, either click A or B. Okay, looks like most people have answered the question. And the majority of you got it correct. 73% said that, in fact, the answer is yes, that the patient had a fall. And 27% said no. And this is that subtle intercepted fall. So they did not hit the ground, okay? The person slipped, kind of bumped into the wall, grabbed on, saved themselves from falling. It was witnessed and documented, and you had the information. So in fact, you would capture that as an intercepted fall. All right? Okay, so, and this is exactly what I said, an intercepted fall is considered a fall. How about J1900, number of falls since admission? So here, what we want to do is we want to review the long-term care medical record. And again, we can look at physician notes, we can look at nursing notes, we can look at therapy notes, nursing assistant notes, whatever you have in your organization where you might see this information, you want to look at that. If you have incident reports, fall logs, some sort of other quality program that you're looking at, you want to make sure that you look at all of these areas to see if you've captured the falls. So injury related to falls, any documented injury that occurs as a result of or was recognized within a short period of time, for example, hours to a few days after the fall and attributed to the fall, will be considered under, or should be considered when you're coding injury related to a fall. And we're going to go into some of the subtleties of this in just a moment. So the coding instructions, we're going to complete this question for planned discharge, unplanned discharge, and the expired assessment. And we're going to determine the number of falls that occurred since admission, and then we're going to code the level of the fall-related injury for each of those falls, and then code each fall only once. So if a patient has multiple injuries in a single fall, we want to make sure that we code it for the highest. So you wouldn't capture it twice. So if I had a fall and I had bruising and a small laceration, and then I also had a fracture, maybe a fractured wrist or something like that, we're not going to code the injury except for major. We just code the major injury. So you don't count it twice. You just want to count that fall once and just go for the highest. So we have a couple of coding options. So what you'll notice is there's A, B, and C here where we're going to code. And right now we're going to talk about coding no injury. And for each one of these, you're going to code 0 for none if the patient had no injurious falls since admission. You're going to code 1 if the patient had 1 non-injurious fall. And code 2 once they have 2 or more. So once they've had 2, they could have had 10. It doesn't matter. We're going to code it as a 2, and we move on. Right? So when we answer this question, answer it individually, did they have any falls with no injury? So that's what that first question is asking you. Okay, the next question, so question number B, is saying, okay, did the patient have any falls with injury, but that didn't rise to the level of a major injury? So that's what we say except major. So we want to say how many falls did a patient have where they had injury, but it didn't rise to the level of major, and that's the number that you're going to put in there. So you'd be coding 0 for none, code 1 for 1, or code 2 for 2 or more. So some of the definitions, except for major, are written out here. We have skin tears, abrasions, lacerations, superficial bruising, some hematomas, maybe some sprains, and any kind of fall-related injury that causes the patient to complain of pain. Now, one of the questions, or one of the frequently asked questions is this everything? Is this an exhaustive list? It is not an exhaustive list. These are just some examples to give you a sense of what they're thinking about is an injury, but it doesn't rise to the level of major injury. All right? Okay. And then we have the last section here that we're talking about for this set of questions, which is letter C, which is major injury. So again, the same coding scenario. Did they have code 0 if they had no falls with a major injury? Code 1 if they had 1 fall with a major injury? Or code 2 if they had 2 or more falls that each one of those falls had a major injury? Right? So that's important. These are little subtleties, but make sure that, and that you're not capturing a fall twice. We don't need to capture that. So what are some of the examples of major injury? Fractures, dislocations, closed head injuries with an altered mental consciousness, subdural hematomas, and they can go on from that. Again, this is just some samples. It's not an exhaustive list. So let's go through a couple of quick scenarios. So, and then this is in relating to coding J1900. So what I would ask you to do is pull out your, so this is coding scenario 1. So if you pull out your sheet, and for those on the web, if you have printed this down, it says section J, coding scenarios, practice coding sheets. So if you take this sheet out, and there's pens on the tables, and just start with the first one. It says coding scenario 1, coding scenario 2, and 3. I'm going to describe a situation to you, and then I want you to code it. So this is the first coding scenario. So we're going to walk through it. At the same time, I'd like you to go ahead and encode that section. So we have Mr. J. He's reported he was ambulating to the bathroom with his walker when he stumbled at the bathroom door and he fell. On assessment, the nurse found 2 large skin tears on the patient's right arm, bruising to his right lower leg, and a laceration above his right eye. All his wounds were cleaned and dressed. 2 days later, Mr. J complained of pain in his right fourth finger, which was noted to have slight swelling and some bruising. An X-ray revealed a non-displaced fracture of the finger. So based on this scenario of Mr. J, I want you to go ahead and code J1900 A, B, and C, and then we're going to go through the coding scenario. Everyone done? So quick. Okay. So here's what we were just looking at. Okay. So the first one, did he have no injuries? Did he have a fall with no injuries? No. He might have had. He might have had other falls, but based on the limited information that we have today, we don't have a situation where we have documented fall with no injury. All right. How about the next one, B, injury except for major? How many falls did he have with injury except for major? Any thoughts? 0? 1? 2? What? 0? Okay. So we're hearing 0, and that is correct. And then how about injury with major fall? 1. Okay, so you did a great job. What could trip people up, and so I just want to make sure that we clarify this, is some people may wanted to jump to all those descriptions that we did of bruising and lacerations and all of this other stuff. And then the fact that we had the fracture that wasn't identified until a couple of days later. But we could attribute that fracture back to that fall. So now that fall rises to the level of a major injury with the fracture. Does everyone understand that? Is that clear? Okay, great. All righty. So let's see. All right, so we talked about this. I already went through that. Get ahead of myself here. All right, let's look at coding scenario 2. So again, you have your sheet. Mrs. K was found on the floor in front of her wheelchair, and upon exam, no obvious injuries were noted. And then 4 days later, Mrs. K was again found on the floor in front of her wheelchair, and she had no injuries. Then 7 days after the first fall, Mrs. K's roommate called for help after witnessing Mrs. K get out of her wheelchair and fall on the way to the bathroom. When the staff arrived, Mrs. K was on the floor bleeding from a large scalp laceration. She was sent to the emergency department and was treated had 12 staples and returned back. So how are we going to code this patient? I'm going to give you a second. So this is our coding area. See some people thinking this through. All right. So let's start with J1900A. I forgot the person's name, Mrs. K. It's after lunch, guys. Okay, did Mrs. K have any falls with no injury? Okay, and so what would you code that? 2, right. Exactly. What if she had had 4? Still would have been 2, right? 2 or more. It doesn't matter. She could have had 20. Hopefully you would have done something about that, but whatever. So she could have, but so it's 2 or more. All right, great. So the next question then we have is J1900B. So now we're looking for injury except for major. So we're hearing 1 in the room here. On the web, I can't hear you, but I'm assuming that you would have said the same thing. Okay, so we have 1 fall with injury except for major. And how about major? Any falls with major injury? 0, right. So let's talk through why we coded this patient that way. She had 2 falls with no injury and 1 fall with injury except for major. So she had a significant injury, right? We're describing this large, probably very bloody laceration to the scalp. She has to go to the hospital. It's cleaned up. She has staples. And based on the scenario, we're not giving you anything more. She obviously does well. So she has an injury. It's significant, but it doesn't rise to the level of major. So you did a nice job with that one. So these are some good scenarios to use with your staff in training. Continue, especially when you're getting new staff in orientation, maybe take some of your own scenarios, things that are happening, complex things that are happening in your organization, and making sure that people are consistently coding. So J1900, so let's look at this patient. Miss A was ambulating in the hallway when she stumbled and started to fall. She grabbed the railing, but hit her head on the wall. The incident was witnessed by the nurse, who immediately assessed Mrs. A. Mrs. A was noted to have tenderness on her right temporal region. Vital signs were stable, and a neuroexam was normal. A few hours later, Mrs. A complained of a headache and nausea. Since she was on warfarin, she was sent to the emergency department for evaluation. A head CT scan revealed a subdural hematoma, and Mrs. A received treatment and returned to the LTCH after 2 days. So let's code this patient. Give you just a second. Okay, looks like most people have it coded. All right, so let's look at J1900A. Falls with no injury. Did she have any falls with no injury based off of what I gave you? No, so we'd code that as a 0. Good. How about B, injury except for major? Did she have any falls with injury except for major? No? Okay, so we're going to put that one as a 0. And then how about falls with a major injury? She had 1. Right. Exactly. And why? So it was a major injury, but it was a result of an intercepted fall. She intercepted her own fall, right? But she still had a major injury with it. So that intercepted fall is still considered a fall. So that was the idea behind that question. All right. What we're going to do now is we're going to go through the case study. I think you were reading it this morning. Most people, I think, read it through. So take the case study. This is Mr. F. We're going to work as small groups. I said 10 minutes here. I don't know that it's going to take 10 minutes, but go ahead, read through the case study, and answer the falls questions, J1800 and J1900. We'll give you just a couple of minutes to do that, and then we will talk through the results of that section. All right, So since it seems like everyone's pretty much done, hopefully those watching on the web had the opportunity earlier to read the case study through, and so you kind of had an idea about some of the answers here. So let's review the case study. So for question J1800, any falls since admission, how would you code that question? Yes, okay. And that is, in fact, correct. Mr. F experienced 2 intercepted falls during his LTCH stay, and if he had not been intercepted by another person or caught himself, he would have fallen. So, in fact, yes, he had falls. Okay, so now we're going to go through just like we were just doing the coding scenarios. J1900A. So this was asking the non-injurious falls. So on the discharge assessment coding, what would we have coded this patient for falls with no injury? 1. Okay, correct. So Mr. F had 1 fall noted with no evidence of injury or on physical assessment, and he had no complaints of pain or change in his behavior documented after the fall. He seemed fine, okay? So that's great. How about B? And so that's the question that's asking falls with injury except for major. 1. Okay, we have 1. Everyone agree? I see nodding. All right, great. So that's correct. Mr. F had 1 injurious fall except for major since his admission. So he had a fall with some injury. Now 19C, and that's asking about any falls with major injury. And did he have any with major injury? No? So we would code 0, none. Great. So he had no major injurious falls since admission. So Section J captures any falls or injuries from falls since admission, and it applies, as we had already said, to the planned discharge, the unplanned discharge, and the expired assessments. And it's just important to remember the definitions of for falls. We already went through these, but it's unintentional change in position, coming to rest on the ground floor or onto a lower surface. And I think that's a pretty standard. Mm-hmm. So this question? Okay, yep. So this is case study 1900A. So he had 1 fall with no evidence of injury or physical assessment? Oh, okay. So I think that, yeah, and I didn't highlight it here to go through this. Hold on 1 second. On page 2? So 4? Thanks. Oh, so yeah, I'm sorry. Okay. So it says, on June 14, 2016, during physical therapy, Mr. F is attempting to ambulate 150 feet and is lowered to the ground by the physical therapist when his legs buckle beneath him. So that wasn't a challenge. I mean, the challenge that we're talking about is, balance challenge. There, he was going to the ground, and in fact, he was lowered to the ground. He, assisted down to the ground by the therapist. So that counts as a fall. Great. Okay, so we talked about falls. The third bullet here, not a result of overwhelming external force. Just make sure your staff understand that if there's this overwhelming external force, a door hits them, a cart pushes into them, some other thing happens that is not considered a fall. So actually, an additional question that was asked is what happens if that door hits that person, like pushes them down, and they fall and they fracture their hip? So it's an accident. and they had a significant injury, but it wouldn't meet the definition of a fall with major injury. And then the intercepted fall we talked about, it is when they would have fallen if they hadn't caught themselves or someone else hadn't intercepted them. So make sure that you continue to educate your staff, especially new staff who may be coming on board. You know, there's always a big push, and so for this group, you've been doing this since April, right? And you did this huge amount of education, and which is great. But I guess the thing I would say to you in your action planning is, what are we doing for when we're turning staff over? We have new staff. What is it for orientation? Are we remembering that we need to get all of these people up to date? Even if they won't be completing this particular section of the form, it's going to be important that wherever you document, that they document the right types of information so you can gather the information. So just don't forget about the new employees. And, you know, we think, oh my gosh, we're done. You know, we've gone through the education, we've gone live, we're figuring this out. But these are here to stay, so just make sure that you have some sort of an enduring process in place. Auditing a few assessments to ensure accurate coding. I think that's a great idea. Don't ever assume that you should probably put some sort of auditing process in place periodically so that you just, you know, that we call this, if you've ever done research and stuff, it's an inter-rater reliability. If two people are completing the same assessment, would we get the same answers? And often it gives you an opportunity to say, we have a little knowledge gap or understanding, or people are making assumptions and they're not looking at the manual to help guide them. Or, you know, Sally told them to do it this way. Well, Sally doesn't quite know what she was talking about, or she misunderstood it. And so what we see is this repeated going forth of inaccurate information. And you wouldn't find that out until you start to look and start to audit. And that goes for everything, not just falls, okay? And then practice coding in a variety of scenarios. It's always great if you have an opportunity where you have a really kind of a complex situation. Make sure you pull those out and keep those for future training. Nothing better than taking your own patient, your own documentation to use as training materials in your organization. All right. So I'd like to open up the floor if there's any questions from the floor related to Section J that we haven't already covered. If you can come up to the mic, only so that we can hear it on the web streaming, that would be great. Sorry.
I just want to clarify that with the case scenario, that the patient, his fall, I think it was the one with the injury, that he actually wasn't at the LTAC when he fell. He was outside, I think it was an interventional radiology, so he actually wasn't at the LTAC receiving care there, so that still counts?
Yes, it does.
So
yeah.
Even though it falls into the whole interrupted stay thing, he wasn't there, he still gets counted as a fall.
He's still under your responsibility, and still would be counted as a fall. Okay. And so a lot of these items were taken from, these particular items were actually taken from the MDS, and so this actually is a reality in the skilled nursing where someone goes out for home visit and stuff, and if they have an injury or something happens outside of that environment, it still needs to be captured. Now, if they had a fall with no injury and they didn't tell you, you know, unless you have a magic ball, there's no way of you knowing that information. But I would encourage family and friends and significant others or whoever's taking them out to make sure that if there's any kind of incident, anything that happens when they're outside of your care, that gets communicated, because that may be an indication of something else that's going on with that particular person. Again, if you could just come up to the mic.
So just with the same scenario, if the patient fell and had such a bad injury that they ended up getting admitted then to the short-term acute and didn't come back within 3 calendar days. So now it's out, they're not admitted anymore. Now it's an unplanned discharge. Is it still during that admission, or because now the patient had left the LTAC, they're in the STAC?
So they go so they're out 4 days, past your 3 days. That's actually a good question. I'm looking to, is Ann in the room? No? Yeah, it's still full. I just want to make sure that you still would capture, I think you'd still capture it on your discharge, unplanned discharge assessment, but I do want to clarify that one. So I'll get back to you before we're done. If someone can capture that for me. Anila, can you grab that? Great, thank you. We have other questions? And then that will go into our frequently asked questions, so that's a good question. We'll add that in so that someone else who has that exact question will have an answer.